Ready?
Yep.
Well, it's so good to be here at 6:30. Appreciate the opportunity. I'm going to talk about, I was asked to talk a little bit about the high white counts and leukemias and doing cytoreductions. So I thought I'd throw something together and share it with you. I have to admit that some of it's clear as mud with regard to indications. There's some that are clear for therapeutic apheresis cytoreductions, but other of it is sort of subject to debate. And I'll be sharing some of the opinions out there, and some are somewhat contradictory at times. So anyway, so the title of my talk is Hyperleukocytosis and Leukostasis, otherwise known as How to Fool the Nurses into Thinking I Know What I'm Talking About. So here we go. Well, what is hyperleukocytosis? Hyperleukocytosis is actually a condition that's defined by the laboratory, and depending on where you read, it's a white count that's above 50,000 per microliter, or a white count above 100,000 per microliter. So it's a laboratory abnormality that we identify in patients. Leukostasis, on the other hand, is a clinical condition. Otherwise, or sometimes known as symptomatic leukostasis. And this is a medical emergency. And it's most commonly seen in acute myeloid leukemia. It's seen sometimes in chronic myeloid leukemia when it's blasting off into what looks like an AML type phase. It can be seen in ALL and some other conditions as well. It's characterized by a very high blast count and symptoms that are secondary to decreased tissue perfusion. And so remember that leukocytosis is the laboratory abnormality and leukostasis is the clinical condition. So in the latest special issue that came out just a few weeks ago, it was described as this: hyperleukocytosis is circulating white cell or leukocyte blast count, or leukemic blast count of greater than 100,000 per microliter. And it's often seen in AML, and we consider hyperleukocytosis to be greater than 100,000 in AML. And in ALL, acute lymphoblastic leukemia, we consider it to be a white count of greater than 400,000. And it's often accompanied by various syndromes, such as tumor lysis syndrome, disseminated intravascular coagulation, leukostasis, which we talked about. And when you present with a leukemia that's associated with a very high white count, the prognosis is worse. It's often associated with the subtypes of AML, particularly subtype M4, which is acute myelomonocytic leukemia, and M5, which is acute monocytic leukemia. And in acute monocyte leukemia, the blast counts can often be less than 50,000, and you can, but you still have hyperleukocytosis. How do we diagnose it? Well, you have to move fast often in these patients, so it's diagnosed often at the bedside. Patients with that have leukostasis, so we're talking about the clinical diagnosis, not the laboratory diagnosis. You see it in patients that have leukemia and a white cell count greater than 100,000 in AML or greater than 400,000 in ALL, who present with accompanying symptoms thought to be due to tissue hypoxia. And this is most commonly, and you'll often, I think if you call or if somebody calls the docs about doing a cytoreduction in the middle of the night, you'll often, the first question is there neurologic or respiratory symptoms? And those are the most common associated symptoms with hyperleukocytosis that make you think that you've just jumped into the syndrome known as leukostasis. So you must have a high degree of suspicion that you've got leukostasis going on because you need to move. It's sort of like TTP, where you want to move as quickly as possible when this occurs. The 1 week mortality of a patient that's got hyperleukocytosis and leukostasis is about 20 to 40%, so it's very lethal. We hang our hat on 100,000 and 400,000, but if there are the symptoms and it's an AML or an ALL, we often pull the trigger on those folks because you can actually have the leukostasis syndrome at counts that are lower than that. And so we tend to err on the side of performance of the procedures as opposed to arguing whether they've hit the magic white count number. This is what it looks like. Those are white cell plugs in the microvasculature, and you can imagine what that does to kidneys, lungs, brain. It not only plugs up the vessels and causes ischemia, but these cells, as I'll tell you, often release other mediators and cause damage that can lead to further problems with ischemia and other injury. So it's not just sheer physical blockage. There's other biological stuff going on as well. Leukostasis is thought to be the result of the clinical entity is the result of end organ complications, where you get these microvascular leukocyte aggregates. You get hyperviscosity, so the blood sludges through the small vascular beds. This leads to lack of oxygen in the tissues that are supplied by these vascular beds. Can lead to the point even of the tissues then dying in that area, and or you break down the integrity of the vascular system and you start to get hemorrhage into the tissues and organs as well. It's thought to be due to large cells that don't bend as well, so they're not as rigid, so they're a little bit stiffer. They don't flow very well, rheological properties, and then they also might be expressing or seeing the expression of adhesion molecules and start sticking to the walls of the vessels as well. Myeloid tends to be, you can see leukostasis at lower cell counts in myeloid conditions as opposed to lymphoid conditions because of the nature of the cells. The myeloid blasts tend to be larger, less deformable. They produce more cytokines which cause problems. So they're more prone to activate inflammation and expression of endothelial cell adhesion molecules. So the blasts, as they sludge through the small vascular beds, not only they don't flow well, they don't deform well, but the myeloid blasts more than the lymphoid blasts also produce some nasty biological response modifiers which make a bad situation worse and make the cells even stickier in those vascular beds. So what are the manifestations of leukostasis? Well, the CNS manifestations are, they're fairly non-distinctive. This can happen in many situations, but when it happens in the setting of hyperleukocytosis, you got to think about leukostasis syndrome. Patients can be confused. They can have a lower level of consciousness. They can complain of dizziness, headache. They might actually be beyond confusion, be delirious. Some may fall into a coma, and some actually may suffer from bleeding as a result of this condition. So you can get actually intracranial bleeds with hyperleukocytosis in leukostasis syndrome. The pulmonary complications are hypoxemia, diffuse alveolar damage, so you can actually start to damage the air exchange areas because of the sludging of the vessels. And you can get out and out respiratory failure where people end up having to go on and become intubated as a result of the inability to exchange oxygen maximally or at least effectively. And there's actually been a grading scale that's been developed for leukostasis, which might be helpful in deciding whether you have the clinical condition or not. This is the grading system that's been published, and you can see it falls in the group 1, 0 through 3, and it's based on severity of symptoms and the degree of limitation that you have. Pulmonary symptoms, and as you go from 0 to 3 it gets worse. Neurologic symptoms, as you go from 0 to 3 it gets worse, and other symptoms such as fatigue, even down to other sort of vascular consequences such as myocardial infarction, priapism, or ischemic necrosis of various sites. So this can be helpful sometimes in deciding whether leukostasis is present. I'm not sure how often it's used at the bedside. Usually this is a fairly rapid sort of gut feeling kind of diagnosis. You see somebody who comes in, very high white count, blasts, and is confused or having trouble breathing. You really don't pull the table out. You kind of pull the trigger on what you need to do. But it's nice for publication. Now, it can occur in other leukemias than AML and ALL, but it's rare. CML with blast crisis is another one where it can occur. Chronic myelomonocytic leukemia, it can occur occasionally, especially if when the white count's greater than 100,000, so you have hyperleukocytosis with a high LDH level, so that leukostasis can occur in that setting. In the chronic phase CML, when the white count is greater than 500,000, and CML is interesting because when you look at the peripheral blood, it sort of looks like you're looking at the bone marrow. You've got all different types of precursors and mature white cells floating around at very high levels. But if you get above 500,000, you can actually not only just have hyperleukocytosis, but you can also have other complications, and they tend to develop priapism. I think we had one of these just a few weeks ago, where that was the reason for doing a cytoreduction in the middle of the night. Was a patient came in with priapism. So it can occur in others, but it's rare. So as we talked about before, and there's some overlap here because this came from different sources, but you can see that it's more common in AML than anything else. Hyperleukocytosis occurs, now this is the laboratory abnormality, in 10 to 20% of patients that present with newly diagnosed AML. And it's most common in M4 and M5, as we talked about. And leukostasis typically occurs in a white count over 100,000, just to reiterate what we've talked about. ALL has hyperleukocytosis, and remember, hyperleukocytosis in ALL is greater than 400,000. Occurs in 10 to 30% of newly diagnosed ALL patients. It's most common hyperleukocytosis is most commonly seen in infants, people who develop ALL at ages 10 to 20 years of age, males, and when there's a T-cell phenotype of the malignancy. Now, leukostasis is rarely seen in ALL, but it does occur, not as much as AML. And it's more common to see tumor lysis syndrome as the cells die from either spontaneously or from the therapy to reduce the blast count and the cell count. And you can see DIC in association with the ALL as well. CLL commonly has a high white count, just like CML, but it's rare to see hyperleukocytosis, or rare to see leukostasis in CLL.